Hello, everyone. My name is Sandeep Nathan. I'm an interventional cardiologist at the University of Chicago Medicine in Chicago, Illinois. I'm here at TCT 2021. It's a pleasure to be with you, and I'd like to walk through a couple of cases with you where we used Shockwave IVL for a very satisfactory technical result for coronary intervention. So case number one is interesting because on the face of it, it really jumps out as a very straightforward lesion. And I think there's a lot of learning here because we focus on the technically complex lesions, the lesions where we look at the angiogram and say, this is going to be a bear to tackle. But in this case, 68-year-old gentleman with a non-ischemic cardiomyopathy that I've been following for a number of years, prior mitral valve repair, as you can see here in RCA stenting, presents with new onset angina and a pretty compelling reversible defect in the lateral wall. And looking at the angiogram, what you see is that there is an obtuse marginal. It really doesn't jump out at you as something terrible, but there's an obstructive lesion at the ostium of it. Not a lot of angiographic calcium. You've got intermediate disease in the LAD, and the RCA stents are patent. So first, we sort of clear the air about the LAD. In the first panel, what you see is an IFR wire going down 0.95 non-ischemic, and we get through the OM lesion with a run-through wire, a workhorse wire, and we dilate with a 2.5 by 12 NC balloon. One of the shifts in my practice has been to pre-dilate with NC balloons in the overwhelming majority of cases because you can really kind of test the water with that, perhaps avoid some balloon ruptures and so forth. But at 20 atmospheres, you can see that there's still a pretty tight waist in that non-compliant balloon. We shift the balloon back and forth just to see if, maybe there's variable compliance along the length of the balloon. But what you see, the third still frame is, once again, there's a very tight napkin ring. So this was interesting because, once again, not much angiographic calcium on the blown up still frames. You can see that perhaps there's a nodule there, and that turned out exactly to be the case. So buddy wire in the obtuse marginal and angiosculpt balloon would not cross. A volcano eagle eye ibis would not cross. And so we went in with a shorter, larger, non-compliant balloon. So 2.75 by 8 millimeter non-compliant balloon. We figure maybe we'll use some focal force here. We've got a second wire down, so sort of a poor man's angiosculpt. And at 24 atmospheres times multiple inflations, we still have a pretty tight residual waist. I think this would be a case where it would be very reasonable to sort of pivot and consider atherectomy with leading edge ablation, of course. But I think, the problem now is that the vessel is dissected. So the edges of that lesion have dissected while the waist still hasn't given up. And so I think it's a perfect application for C2IVL. Interestingly, a 2.5 by 12 C2IVL balloon went out very easily. We pulled the second buddy wire, and we delivered pulses at 2 to 4 atmospheres. At 4 atmospheres, it gave. My thought was that perhaps even the 2.5 was a little bit big, and we were already dissected. So I didn't go up to the full 6, but very good expansion relatively quickly after we started delivering pulses. We ran it out to 80 pulses. Since we have the balloon, we moved it around a little bit to realign the transmitters because I started to get the sense that perhaps there's some nodular calcium there. And then on Neutrovascular Imaging, now a volcano catheter goes down just fine. On Neutrovascular Imaging, you can see a 180-degree arc of calcium, some nodules, and a clear break in that calcium plate. And it's relatively deep. It's hard to assess how deep it is by IVUS, obviously, because there's acoustic shadowing. But you get the sense from the areas where that arc has broken that it's relatively deep calcium. And there are segments where it's approaching 270 degrees of calcium. So the still frame, I think, very nicely illustrates where the calcium broke. And so now we've got sizing as well, and the vessel, as is usually the case, turns out to be a little bit bigger than we gave it credit for. 2.75 by 18 onyx was deployed at 18 atmospheres. At post-dilated with an NC balloon at 20 atmospheres, and we have IVUS confirmation of full stent expansion, even in the area where there's a large plate of calcium and certainly where there's nodular calcium. So a very technically satisfactory result. The second case I have for you is quite a bit different, and this was a case that was referred into me from an outside cardiologist who identified this very large, tortuous right coronary artery in a 74-year-old gentleman with a history of prostate and bladder CA, abnormal stress test, exertional dyspnea, exertional chest pain, and significant new fatigue. And what you see on this rotational angio is, first of all, an enormous RCA with a very large distribution, but you also see nodular calcium after a nearly 360-degree twist in that vessel that is sort of caking both walls of the straight segment of the mid RCA. So this poses, I think, a very significant technical challenge for any type of therapy that you're going to deliver, whether it's atherectomy, whether it's intravascular lithotripsy. And when you look at the equipment choices we made, 7 French by 25 centimeter pinnacle sheath, a 7 French multi-purpose guide, because the takeoff of this RCA is also a little bit unusual in that it's pointing straight down, almost like a vein graft, followed by a 360-degree loop, which you fully appreciate when you try to put wires or any devices past it. We're crossing with a workhorse wire and then following with a Corsair Pro. And then we realized that that was going to be a challenge. So we used balloon-assisted inchworm technique, or balloon-assisted tracking, to get a guide extension. In this case, we initially tried a guide liner, and a 6 French Medtronic telescope actually went further than the guide liner did. So we're kind of inching our way past the 360-degree loop to establish a base of operations a little bit further on and just proximal to the nodular calcium. We did try to push an imaging catheter down there. That was kind of a no-go, so we decided to go ahead and treat and then and image afterwards. 3.5 by 12 NC balloon in the mid-RCA, followed by a 4.0 by 12 Shockwave. I don't want to oversell this. The Shockwave did not deliver easily, but it did deliver. And I think in these cases where you have a really challenging delivery, it's probably better to fracture distal to proximal and realign the transmitters in that way, rather than trying to push a winged balloon on the hopes that the initial fracture was enough to facilitate its delivery. And so that's what we did from distal to proximal in that segment. The telescope guide extension was invaluable. I think the question often arises, can you push a large IVL balloon through a guide extension? I think this case very nicely demonstrates that you can. The 5.5 French effective lumen telescope was more than adequate to deliver the balloon and to also get the balloon out completely. Didn't jam on the way back, even though it was winged. We once again used a 3.0 by 12 semi-compliant balloon to track our guide extension all the way down into the mid RCA. In order to sort of finish the case with a 5.0 by 30 millimeter Resolute Onyx DES. You can see it coming through the guide extension and tracking through the 360-degree loop, and really covers that area pretty adequately. After a couple of attempts, we were able to get it just so and deploy at 16 atmospheres. I think there's also the concern that, perhaps we hadn't fractured all of the nodular calcium. So, we deployed at 16 and then we took a picture, decided we weren't entirely happy with it. So we post-dilated at 18 to 20. The RBPL, reminds you, for this balloon is 18. So we didn't want to get into crazy high pressures, but fortunately we didn't need to get into crazy high pressures. The stented dimension that was yielded by that was about 5.2. And at this point, an IVUS tracked just fine through there. We get a very technically satisfactory result, as you can see on the final rotational angio. And the nice postscript to this case is that this gentleman had complete resolution of symptoms, the ones that he complained of, but also things that he didn't even acknowledge were related to his coronary artery disease, his fatigue, his inability to walk long distances, and so forth, all resolved very well. So the last thing I want to show you is that, a couple months later, I mentioned he's back to normal, and this is an unsolicited quote from him. He said, "This is the best I've ever felt in a very long time," so enormously gratifying. I also posted a Twitter poll just to kind of see what folks would do with this. When I got this film from the outside institution, I posted this Twitter poll, and by a narrow majority, orbital or rotational atherectomy was the choice. Although about 40% of people, respondents, did say intravascular lithotripsy. So It is kind of interesting to see where everyone's head is in terms of treating nodular calcium in a very large vessel, and I think that image very nicely demonstrates all the nodules that are sort of studding the mid portion of the RCA. Nice postscript to this case. I'll stop there. Thanks so much. So the question is, what tips and tricks are good for treating nodular calcium? I think it's a great question. I think realigning the transmitters, the emitters, to try to get, right on the nodule. I don't think nodular calcium is the kind of case where you can be sort of sloppy with technique, or just sort of put the device in there and what you get is what you get, run out the 80 pulses and move on. I do think you have to be a little bit meticulous, as in the second case. When you've got difficult crossing, probably makes more sense to go distal to proximal and really sort of budget your pulses, which is also a strategy that we use for bifurcation disease. If the primary vessel doesn't require the full 80, perhaps you can take the bifurcation, the branch, or if you've got a grafted LAD, but you want to salvage the LAD ostium when you're working on a circ, for example. You can sort of re-emit, you can re-advance your IVL balloon and be sort of meticulous about aligning your transmitters.